top is down, and it doesn't, it only is an audio. It's not, it's just going to be the full script quality.
Okay. And you're doing this for any project?
Yeah, I've covered 500 programs.
Okay. All right. I'm just trying to see if there's a better way to put, better place to put this instead of right here.
No, it's, I usually leave it right on the table. Actually, it can go even like this. It'll just catch the sound. It'll catch it fine.
Okay.
It can't be anywhere else.
Because we haven't had one of these set up at one of our hearings before, right? Did you set one up there?
I've been in mental health. If you want to see the list of my tapes, I'll show it to you sometime.
Okay, yeah.
I just, this is a camcorder. It really takes fabulous sound.
Okay.
And it's not, but what happened is when it was shipped, okay, it doesn't do video.
It doesn't record?
It does audio.
Okay.
So that's why it's, so I just, it's a $600 to $700.
Yeah, I understand. Okay.
Just going to do that.
Okay. All right.
I have the window open. Can you hear me? Excellent. Yes, I can, clearly. Thank you. Please do. You might want to pull the screw now.
Oh yeah, so mine's case. Yeah. And then it's this one. And then 117.
I'm at the testimony table.
It's like saved. I know. Good and bad.
I can find it.
Yeah.
Okay.
She could have testified.
How's the weather down there?
Yeah, like it's just decide.
And New England has your weather up here. Well, I can't say unfortunately, but
Your what?
you have the weather that we had last week. The humidity is terrible here. The mic's coming in clear?
I know. Yeah, I guess they want to probably.
I tested like 5 or 6 of them. We're looking good so far.
Somebody's mic.
Yeah. Yeah, right, I know. Were you here the hearing? The crazy one when they were like, people weren't speaking to the mic and they just went up in the room, so everyone was just yelling. Every time someone spoke.
Oh, I was there.
Yeah.
Beginning of it, yeah. I know.
They like keep forgetting.
Yeah.
I know.
Our maximum.
Just hard. Yeah. I think these aren't. Yeah. Yeah. Mostly recorded.
One of our members.
Yeah. I know. I feel bad for people that like. Yeah. She could be answered. She may still come. Sort of assume she might still come. No, you really. Not so far, because the church was around it. We can just Sarah gets here when we can't do it right now. You know what I mean? It's more like, yeah. Oh, thanks. I told her. Oh, really?
Good afternoon, everyone. I hope that our room will stay at a temperature you can tolerate. We're going to try and open the doors as long as there's not too much noise out in the hallway to get some air in here for you. So I am Denise Garlick. I am the House Chair of the Joint Committee on Mental Health, Substance Use and Recovery, and I am joined by my friend and colleague, Chairwoman Flanagan, and we welcome all of you here. Before I begin, I'd like to take this opportunity to recognize the representatives who are here, who is Representative Jeff Roy and Representative Will Crocker. Representative Dan Ryan, who's the Vice Chair of the committee, is on his way. And you might know that it's a particularly complicated day in the State House. There's several hearings going on, several large hearings. You may know that representatives serve on several committees, so you may see folks coming and going as they're trying to balance all of their responsibilities. Today's hearing, we will hear testimony on the bills related to scope of practice and prescriptions. I want you to know that the audio of this hearing will be recorded. If you wish to also record audio or do a video, we ask that you speak to either me or to my committee staff. And my committee staff is to the far end of the table. Elaine Tisler, if you'll check in with her. In order to best serve the entire audience here today, we have listening devices that are available for anyone who may be hard of hearing, as well as closed captioning on the screen. I ask that all speakers speak directly into the microphone, not only so that people in the room can hear you, but it is the way the transcriber gets your words, so you need to speak directly into that microphone. I'd also like to say that we try very hard to encourage people to limit their testimony to 3 minutes. I know that this is very difficult when we all have so much to say and we want to share. I wanted to say something about that. One of the things is I want you to know that as you come to the microphone, we already consider you a respected and credible witness. So to maximize your time, to get to the meat of what your testimony is incredibly helpful, and don't feel like you have to put out the bona fides of your organization or the other credentials that would just use up time that would keep us from getting to the very reason why you're here. We're going to be taking the bills in order as they appear on the agenda, and we may take legislators and other officials out of turn, particularly on this day where people are scrambling to be in different hearings. I want you to know that it may seem to you that the committee members ask limited questions. That's for 2 reasons. One is that we are all very respectful that people have come from all over the Commonwealth to bring their testimony to us, and we want to make sure we have an efficient hearing. But I want to reassure you that every committee member is given all of the contact information that you give to us on those sign-in sheets, as well as any written testimony that we receive, and they have the full transcript of the hearing. So there's a way for them to circle back to you and to close that loop as well. And I just want to introduce to you, my legal counsel is Barry Hawk. If Barry Hawk is in the room, Barry, if you would stand, please. We want Barry to be available if during the hearing you want to check in with him, or you think that you need more time at a different time, or want to set up a meeting, if you check in with Barry. You may know that Rob Reed is the committee researcher, Elena Tiskler is the researcher for the committee, and I'm hoping you met other good staff people out at the sign-in desk. So with that, we will get started. Ready? So the first bill that we will hear, if I may, Rep. Dylan Fernandez has joined us, and Senator Flanagan is there. Would you like to introduce yourself or anyone else? All right. As we go to the first bill that's on our agenda, first I want to recognize Representative Ruth Balzer.
Thank you, Madam Chair, members of the committee. Thank you for taking me out of turn. I'm here to speak in support of House Bill 1060, an act relative to increasing access to psychological services. This bill, a simple bill, it would require Mass Health to cover services provided by licensed psychologists. We have this regulation in our state, which I don't know the genesis of, but it prohibits Medicaid recipients from receiving treatment from independently licensed psychologists. It's important to note that that makes us the only state out of 50 for whom this is true. Psychologists, this bill does not in any way alter anyone's scope of practice. This bill just makes sure that Mass Health does what all the commercial plans and other public plans do, which is to cover licensed psychologists. And you'll hear more, I'll be brief right now, you'll hear more from psychologists and others, but to make sure this is really an important issue, not only to psychologists, but obviously to the mental health consumers who need those services and can't get them right now under some of the plans in Medicaid.
I thank you for a brief testimony and want to reassure people that you are always available to all of us as an incredible resource on mental health.
Thank you.
And now we will go to the first item on the agenda, which is we're taking House Bill 3204 and Senate Bill 1110 together. They are sister bills. So on those bills, the first person asking to testify is Dr. Erin Metzger. And this bill is an act relative to psychotropic medications. And actually, Helen Janis is going to testify as well. Yes, Helen?
Good afternoon, Madam Chair and Madam Chair, members of the committee. My name's Erin Metzger. I'm Director of Psychiatry for Hebrew Senior Life. I've practiced psychiatry for over 25 years, and I'm an assistant professor of psychiatry at Harvard Medical School. I'm representing the Massachusetts Psychiatric Society. Thank you for allowing me to speak today in support of Senate Bill 1110 and House Bill 3204. In the field of medicine, case presentations are a common teaching tool, so with your permission, I'll describe a brief case. Mr. G is an 88-year-old man who, in spite of having advanced dementia, has been cared for at home by his 84-year-old wife, Mrs. G. 2 years ago, when Mr. G developed depression and agitation, his doctor prescribed him an SSRI antidepressant with good results. Recently, however, Mr. G tripped and fell at home, fracturing his hip. He was hospitalized in Boston, underwent successful hip replacement surgery, and was transferred to a nursing home for rehabilitation. He was transferred to the nursing home late in the day, and Mrs. G, who no longer drives, was unable to make the trip into Boston from their home in Medfield. The doctor admitting Mr. G to the nursing home notes that Mr. G has been taking an antidepressant, so during his phone call to Mrs. G, who is her husband's healthcare agent, he asks if the facility can email her a psychotropic consent form which she should then sign, scan, and email back as an attachment to the facility in order that her husband may continue his antidepressant medication that has been helping him for 2 years. Members of the committee, you can probably imagine Mrs. G's response. Suffice it to say, she was unable to complete the requisite tasks, and the doctor was faced with the daunting choice of either continuing the medication without written informed consent, thereby violating Section 72BB, or stopping the medication abruptly, placing Mr. G at risk for withdrawal symptoms and possible harm. This scenario is not hypothetical. Since the publication of the DPH circular letter implementing Section 72BB a year ago, this scenario has been replayed in facilities across the state. After the initial DPH circular letter was released, I was one of a group of physicians who worked collaboratively with DPH to clarify language and update the psychotropic medication list for a revised letter. However, because of the language of the original law, we could not change the requirement for written informed consent for psychotropic medication at the time of admission to a nursing home. The bills before you would allow nursing homes to continue, at least temporarily, medically necessary psychotropic medications when written consent cannot be immediately obtained. The current law requiring written informed consent in order to continue psychotropic medication at the time of admission prevents elderly patients who have the misfortune to suffer from mental illness and/or dementia from receiving the same quality of care at the nursing home which elderly patients without mental illness receive. The bills before you would eliminate the current law's obstruction to providing good clinical care to this vulnerable population. The bills address additional weaknesses in the original law by removing the written consent requirement for 2 other vulnerable populations: those who are at immediate risk for harming themselves or others, and those who are in hospice care for whom a psychotropic medication could alleviate suffering. We similarly support these provisions of the bills. House Bill 3204 allows for temporary verbal informed consent. I'd underscore for the committee that there's ample precedent in medicine for obtaining verbal telephone consent from a surrogate decision maker for interventions as serious as general anesthesia and surgery. In closing, thank you for your willingness to consider the bills which, while short in length, will have a large and positive impact on some of the Commonwealth's most vulnerable constituents.
Good afternoon, Madam Chair, members of the committee. I'm Helen Janest from Milton, Massachusetts. I'm a nurse practitioner specializing in geriatrics and have been for the past 26 years. And I also would present you a scenario to demonstrate the potential impact of the current law. 86-year-old Mary, who weighs about 100 pounds, is a primary caregiver of her husband, who is 91 years old, weighs close to 200 pounds. He's diabetic, has prostatic cancer, congestive heart failure, emphysema, and a history of falls. He also has dementia. And he has sundowning behaviors associated with that dementia. So he has increased agitation and confusion every day about 4 o'clock. Mary gives her husband Risperdal for this. She gives it to him about 3 o'clock so that the 4 o'clock episode won't occur. Sometimes it still occurs, and she has to give him a second dose. Despite the Risperdal, he sometimes still becomes agitated in the middle of the night. He also falls, as so many of our elderly patients do, and fractures his hip. He undergoes a hip fracture repair, but it's complicated by fluid overload. It's complicated by his confusion from being outside of his normal environment, and it's complicated by blood loss and anemia requiring blood transfusion. He's admitted to the rehab around 4 o'clock. Mary, like so many of our older patients, doesn't drive, especially at night. Again, the on-call provider tries to get a written consent so that he can have his Risperdal. However, Mary is not technologically savvy enough to send a fax or an email. She doesn't have anybody to drive her to the hospital, to the rehab. So her husband ends up not getting Risperdal. And again, in the middle of the night when the staffing ratio is one nurse to 26 or 30 patients. He falls in the middle of the night and strikes his head, requiring an emergency room admission. As an incidentaloma, they find he also has a gastric cancer. As he complains about abdominal pain, they do a CT scan. Eventually, Mary's able to get to the hospital where her family is finally able to meet with her, and they decide his quality of life is not going to be worth really giving any treatment, so he is eventually returned back to the rehab on hospice medications, including morphine and Ativan. By the way, he can't get the Ativan because Mary's not there. She can't sign consent. So he has to deal with the anxiety of the dying process without those medications that are required to allay suffering. So the current law, although it's formulated with the intention of protecting patients, has a potential for increasing their distress. It has resulted in the omission of medications these patients may have been receiving over the course of years, or that are essential for humane care. As providers of care for the elderly, we are requesting a 3-day grace period within which written informed consent can be obtained in limited circumstances as described in House Bill 3204. I thank you for your attention.
You're welcome. I'd like to take a moment before we move on to questioning, say as promised, the Vice Chair of the name on his right, Rev. Dylan Fernandez is with us, as well as Dr. Diana Zafio. I have some questions, and then I'll open this up to the committee. I am a registered nurse by profession. I have, although I don't think anyone has a great understanding of how psychotropic drugs work for individuals, depending on the case and that individual's history, I have great respect for the power of psychotropic drugs. It seems to me that we would always want informed consent for anyone to be given a psychotropic drug. So the problem is that you feel like there's a disconnect as people are transitioning between different environments. The language of the bill says that a facility can authorize an individual to get a psychotropic drug. Number one, that language is incredibly concerning. They don't even know what that means. The facility is the nursing home administrator going to say this is okay, but I don't know what that means. But we can all sort that out. The bigger issue that I'd like to ask you to think very creatively about is how do we preserve informed consent in times during the transition? So you see it as a barrier right now. You see it as a barrier right now as people are moving through these scenarios. Even your scenario of the old gentleman, he actually was in the hospital before he went to the SNF. He would have had orders written in the hospital that he could, he should have been on Risperdal at 4 o'clock in the hospital as well, before he even goes to the SNF. So there may be ways to control those threats, but if you would think very carefully about that and work with the committee, in no way would I want to in any way weaken laws around informed consent, but I do understand how conditions can change and how we want to maintain people on these drugs once they have already been on these drugs. So we'll work thoughtfully on that. Are there any questions from the committee? Seeing none, thank you very much. Unless you would like to respond in any way.
I would just highlight again that for all other medications and medical interventions, there's a long precedent for accepting verbal consent over the telephone, and it can be witness verbal consent with someone else from the facility witnessing the phone call. So we're certainly not asking to change the bill as dramatically as removing informed consent. Just it's that written informed consent for this population in particular that's so problematic.
Thank you. At this time, we're moving to Senate Bill 1098, an act strengthening prescription drug safety and drug stewardship. We have no one who is signed to give testimony on this, as well as we're moving to Senate 1099, an act relative to patient choice to promote prescription safety. We have no one who is signed up to testify on that bill. We will now move to Senate 1100, an act relative to opioid prescribing practices and access to patient management. We have received written testimony on this, but I don't have anyone who has signed up to give verbal testimony. We will then move to H3508, an act relative to opioid drug manufacturer assessments. And we have also received written testimony on this, but I do not see anyone who signed up to give verbal testimony. And on Senate 1060, an act relative to increasing access to psychological services. We have heard from Representative Walza. We now have Jennifer Workington, who is signed up to testify. Did I say that correctly, Jennifer?
Very close, Workington.
Thank you very much.
Thank you very much for taking the time to hear what we have to say. I'm Dr. Jennifer Workington. I am a licensed psychologist in the Commonwealth, and I'm testifying in support of Bill 1060, the act relative to increasing psychological services. I've submitted written testimony as well, so I just want to speak a little bit about what this bill is and the impact that not passing it would have on the Commonwealth. Essentially, all this bill does is permit licensed psychologists in independent practice to provide treatment to mass health patients that are not under a managed care. Currently, a mass health patient that is operating under a managed care plan does have access to that treatment. Only mass health patients without a managed care plan. So as you can see, it gets very confusing, and this is one of the things that we're very concerned about. In terms of access to care, consumers, not surprisingly, get confused about who can provide treatment and who can't. Oftentimes, psychologists are included on the list of approved providers, but nowhere on the website does it say that they're not approved to provide treatment services, that it's only assessment services that are offered. So this creates unnecessary delays in access. The other issue that we see for consumers is that it creates a disruption in treatment. So if you have someone that's been in therapy for a period of time and for some reason they transition to a non-managed care mass health contract, all of a sudden they're no longer able to see their therapist. Even if that therapist wants to continue to provide services at the agreed upon mass health rate, that psychologist is prohibited from providing continued services for that patient. And this is true whether it's a temporary shift, so if someone is changing jobs, and it's true if there's a prolonged change. So those are a couple of the things that we tend to be concerned about for consumers. In terms of psychologists, it creates a really untenable situation where if they've been providing services to that client, they have an ethical duty to care for that client, but now they have to choose between sending that client somewhere else, even if it's not clinically indicated, or providing that care completely free of charge. And we see that as a really unfair situation. Currently, Mass Health reimburses for testing services for psychologists. There's been no clear reasoning that I've heard so far about why it's okay to provide assessment but not treatment. We are the only state in the country that has this kind of prohibition. No other health plan in the state has that kind of prohibition. Nowhere does Medicaid or Medicare have that prohibition. So it's really this one area, very specific area, and it's something that we remain concerned about. So we're hoping very much that you will move favorably on the bill and mandate the removal of this illogical and confusing barrier to appropriate mental health care for citizens of the Commonwealth. Thank you.
Are there any questions from the committee? May I just ask you, this is a refile, so we've been struggling with this disconnect for a while. Do you have a sense of the history of this and why we haven't been able to rectify this?
I don't have a sense so much of why it hasn't worked. I think that I'm honestly not sure. I know that we have been working on this for quite some time. We've also been working on the regulatory side to try to make some of those changes. I think to some degree it's this notion of just that's how it's always been, so it doesn't seem like it's a big problem. But we're hearing from our members that are psychologists that this is a problem. And it's something that we are hoping that in this session we can finally fix.
Thank you very much.
Thank you. Any other
At
questions?
this time, we'd like to call Susan Pendel. Susan.
I'm Susan Fendel. I'm senior attorney with Mental Health Legal Advisors Committee. And we wanted to support this bill because people who are low income should have full access to mental health services. And in a way, this is like saying that low-income people, at least ones in certain plans, should not have access to things like lab tests. Psychologists play a very specific role in the mental health system. And in terms of testing and determining what is actually happening with the individual, they perform a very significant function, and also they may also have a therapeutic relationship with the individual, and that should not be terminated merely because they are low income.
Ms. Fendel, if you'd like to stay seated, we're going to move to the next bill. You're the last testifier in this bill. We'll move to the next bill, and you're signed up to testify on that as well. So maximizing your efforts. So, is this ringing a bell with you? I'm reading your face. So on the next bill, which is 1061, an act relative to expanding access and safety of mental health services, we signed up for that as well, and is opposed in that bill?
Do you mind giving me a minute and let the people who are...
No, you're welcome. I thought I was doing you a favor.
Thank you.
Okay, so as I move to 1061, which is the act relative to expanding access and safety of mental health services, I'd like to call John J. Severo. And John, how am I doing with your last name? Is it
Close, Sierra.
Sierra?
Yeah.
Sierra. Thank you.
Madam Chairs and members of the committee, thank you for taking the time with us. I am a licensed mental health counselor in the state of Massachusetts, have been so for the last 10 years, and I provide services in the emergency room as a first-line evaluator at St. Elizabeth's Medical Center. I also have a private practice. And I see clients that often are highly dysregulated, unsafe to themselves, and unsafe to others. This is about a scope of practice issue that I wanted to bring to the attention. It's the second time it's come up, that we would be able to section them for evaluation when we see them in the community or we see them in the emergency room. And at this point, we are unable to do so. Our scope of practice includes assessment, diagnosis, and treatment, just as our sisters and brothers in the social work practice who have this ability to do so. This is not for us, this is for our patients and our clients to be able to get them a full evaluation when necessary. The other part of this bill is Section 35, which is about drug and alcohol. The ability to be, we see patients that are abusers and have been through treatment multiple times and are unsafe to themselves and others as well. And a Section 35 would allow us to be able to section them to a court for a hearing so that an independent body such as a psychiatrist or a psychologist would evaluate them for a commitment of up to 30 days for treatment. So this is clearly just a scope of practice issue. We're asking for parity with the social workers who have the same rights.
So just my own education, I understand this desire to streamline. What happens right now? A psychologist who's with an individual and they feel like this person is a danger to themselves or others. What actually happens right now?
They have a pink paper, it's called a Section 12, and they fill it out. They call the local police department or the EMTs, and they transport them to an emergency room, always an emergency room, to be evaluated.
And this is different how?
This is the same thing. We're just asking for the same rights to be able to do it. Once the person comes to the emergency room, either an intern in psychiatry or a psychiatrist does part of the evaluation. I do the beginning part of it, and I have to then meet with my consult, which is a psychiatrist, and he or she will sign off.
Thank you very much.
Thank you.
Patient. Hang on just for a second, there's other questions. Any other questions from the committee? Yes, okay. Representative, please open.
Thank you, Madam Chair. I just have a quick question about, everything you said is actually clearly lined out right here, so thank you for that.
Sure.
I have sort of a relative question to it. It's just pertaining to what happens to an individual, a patient who might be in a wrong state of mind and say, I'm leaving right now, I want to leave, and they're under your care, and say, I'm going to leave and going to commit suicide right now, or I'm going to leave and I'm going to do drugs right now, shoot up, or do something to harm myself. What do you do in that type of scenario?
There are two separate things. The state of Massachusetts, the laws are not written. If someone says they're going to shoot up, that is not Section 12able, for lack of a better way to describe that. We can't hold someone on that. If someone says they're suicidal, homicidal, or they're unsafe to be in the community, then that would be a Section 12. It can be held up to 72 hours for evaluation.
Thank you so much.
You're welcome. Thank you for your time.
At this time, we'd like to call Joseph Weeks.
Hello.
Good afternoon.
I'd like to say thank you to the committee. Thank you, Madam Chair. Madam Chair, I'm here to testify in support of Bill H-1061 and S-1108. I'd like to echo my colleague, Mr. Ciervo's testimony in that regard. I think that this is a bill that tries to establish more parity amongst the licenses. Currently under Section 12, the ability for a professional to be able to section somebody strictly lies with psychologists, psychiatrists, LICSWs, and police officers. And we have, as LMHCs, a full scope of practice in which we can assess a diagnosis, treat that diagnosis, and be able to actually diagnose somebody. So we have extensive training in the field of mental health. We are simply looking to complete our toolbox and have some parity with our sibling licensed provider professionals. One of the things that is interesting is that if you have a private practice, let's say, and you're an individual that works in a building with multiple licenses, you could have a psychologist, a LICSW, and an LMHC. I currently come from a dynamic just like that. When somebody comes in for mental health services, they kind of have an expectation that you can actually have at your disposal the extensive toolbox that any other license would have. Currently, with the dynamic we have, 2 out of those 3 could actually exercise their full scope and authority, while the patients that I would see would be at a disadvantage in terms of safety in that regard. So really what we're looking for is just to bring our license up to the parity of the sibling professionals. Now that being said, we do have a good relationship with other licenses. I've submitted written testimony from the Mass Psychological Association as well as the National Association of Social Workers, the Massachusetts chapter, as well as the Southeast Police Officers Association as well, amongst other individual practitioners. LMHCs work in an array of different environments, including hospitals, private practices, state agencies. And this is one of those things that I think even coming out of school and being trained in this, you kind of assume that you already have these abilities and then come to find out we don't. So I think that this is something that we're really just trying to just change the language for inclusion. I don't want, we can discuss the actual process, but Mr. Ciervo did a fantastic job of discussing some of those protocols. All this bill does is just allows us to start the process. It's a Section 12A. In order for someone to be hospitalized, Section 12B has to take place. In order for Section 35 to take place, we just do the 35A. 35B would come from the court. So we're just utilizing our ability to make those assessments and nothing more. So thank you very much for your time. I really appreciate it.
Any questions from the committee? Hearing now, none, we'll go back to Susan Kendall, please.
Thank you. Mental Health Legal Advisors Committee is opposed to S-1108. And the reason we are opposed to it is because that mental health counselors and certain of the other professions that do not have the ability to do a Section 12 hold on an individual have a special place in terms of their relationship to people who are seeking mental health care. Our clients, we serve a broad array of clients with psychiatric challenges. I can't tell you the amount of trauma that sometimes occurs due to an emergency, involuntary. Remember, this is always an involuntary hold. And it disrupts the life of somebody. If that person is working, it disrupts their work. If that person has children, it impairs their ability to care for their children. If that person has other obligations, perhaps caretaking an elderly parent, they are put in a very difficult situation. But the key thing is that people who have been subject to involuntary commitment, including these Section 12 holds, are traumatized by it. And very many of them stop seeking mental health care at all. And that is about the worst outcome we could have. The other thing is, the more there are people who are already, professions who are already able to do Section 12 commitments. And when you expand the number of professions and people who can do Section 12 holds, you're inevitably going to have more people ending up at the emergency room. We know that there are already difficulties with overcrowding in emergency departments. We know that there's already an issue of the cost to the Commonwealth of people seeking care in emergency departments. And this is just going to make that problem worse, because more people who can do Section 12s, more Section 12s. And
I'm going to ask Senator Flanagan, please.
Thank you. Thank you for your testimony today. I hear your concerns. My LMHC training was all done in the emergency room. And the people that present to the emergency room are not everyday people who are managing their illness. They are people who are decompensating. There are people who are in need of treatment. There are people who may be acting erratically. And I think my concern is, from a legal standpoint, I can understand what you're saying, but from a therapeutic standpoint, at what point do we have to help someone and take that into our hands before they do something that could be catastrophic to themselves or other people? We're now having this big conversation about what happened at Harrington Hospital and what happens to nurses that are on the front line. And I would say, in full disclosure, my mom's an ER nurse. She's been one for 40 years. At some point, we have to stop saying, let's protect people from themselves, and start saying, let's get them the help that they need. And I think that by saying, and I can appreciate that you're against this bill, but the more people that can help, why wouldn't you want that? Why wouldn't you want someone who is in the emergency room, able to sign that paper, instead of having them boarding or waiting, because you gotta find the social worker, you gotta find the doctor, you gotta find someone else that's there to get them the treatment that they need. When you say it's traumatic and you say that it impedes on their lives and it makes it difficult, well, having untreated mental illness impedes on the lives of their entire family. And my concern is that I don't think the LMHCs want to go out there and Section 12 everybody. That's not the role of any kind of clinician. But if you have that tool in the toolbox, why shouldn't we be able to use it?
because of the unforeseen repercussions of that tool. There is study after study that shows that people who are admitted to psychiatric hospitals from the emergency department are not being treated for ailments that actually cause the decompensation. I think it's important that there be a medically trained individual who
Well, you have to be medically cleared in an ER before you can be psychiatrically treated.
Right, but once you've, why not have the psychiatrist be the one to determine if the person is having these mental health reactions from medication, from some other ailment? We know that elderly people, urinary tract infections sometimes cause what looks like psychosis. And these people need to be examined by medically trained professionals before they are held and possibly transferred without care. And sometimes, even though they're supposed to be medical clearance, as soon as somebody is Section 12, nobody really pays attention to their medical condition. Again, we have study after study.
You can't treat them psychiatrically until they're medically cleared. And so the doctor putting the signature on that paper signifies that they did the medical evaluation. And I used to fight with the medical side saying, give me my patient, like, we need to do this. And I think the fact that it sounds to me, and I could be off base, you're insinuating the LMHCs don't have the training to recognize that. And I think given the training that they do have and given the hours that they do have in their respective fields, to notice when someone needs to be, which is a last resort. I mean, nobody's going to Section 12 someone off the bat. One, there's no place to put them. Two, that's not the best for every patient. And three, who's going to pay for it? But putting those aside, what's in the best interest of the patient? Again, I don't understand why you wouldn't want to give that tool to the toolbox for people who are in that reset. When you're talking crisis, when you're talking, life or death in most situations, to me, why would you want to let them go? If you have one shot at helping them stay alive and one shot at getting them the help that they need, who cares if it's an LMHC or a social worker or a psychiatrist, as long as they get the treatment?
I think it is, again, and again, I can circulate the research on diagnostic overshadowing, where once somebody is given a psychiatric diagnosis or an indication of a psychiatric diagnosis, every complaint they have is attributed to their mental illness, and they are not given the same tests, interventions, or treatment. And I really, it's a stack of studies. And the reason, I think emergency departments should have psychiatrists available, and they should have.
Every office should have a mental health, in my opinion.
Yeah. But I think there are sufficient number of people who can do the Section 12 without increasing the professions that can do it. And in addition, people need to know there are certain professions they can seek out for mental health care without fear of being involuntarily committed, involuntarily treated. And
thank you.
Thank you very much. If you want to submit peer-reviewed journal articles, committee is always interested. I would like to reassure everyone in this room, in my personal practice of more than 40 years, I have not seen that people's physical health is ignored because of mental health issue. At this time, we have no more testimony on 1061 or S1108. I will now move to House 1066, an act providing signature authority for psychiatric nurse mental health clinical specialists. We have testimony, Margaret Chapman. Welcome.
Thank you. Madam Chairs and committee members, my name is Margaret Chapman. I'm a clinical nurse specialist with 35 years of child and adolescent family treatment, and my specialty right now is psychopharmacology at private practice in Hingham, Massachusetts. I am testifying on behalf of myself and also Massachusetts Association of Advanced Practice Psychiatric Nurses, also known as MAPN. MAPN is a professional association dedicated to advancing the science and education of psychiatric mental health nursing. CNS, clinical nurse specialist, to clarify, is one of the four roles of the advanced practice registered nurses. I'm here in favor of House Bill 1066. House Bill 1066 provides that when a law or rule requires a signature, certification, stamp, verification, or affidavit, or endorsement by a physician relating to physical or mental health issues, a clinical nurse specialist may fulfill this requirement. An example of this, and it's attached to what was submitted, is a form for academic tutoring services. When a child is unable to physically be present in school for 14 or more days, a tutor may be requested through the child's school district so that the child can be assisted with their studies when they are not in school. Currently, if a child's therapist or I identify the need for this, the primary care physician is the only person who can sign this form. However, I am the primary person who can accurately provide the information required on this form. Because I am a CNS, I am unable to sign the form. Currently, to expedite these forms to be completed, I often fill in the information, send it to the PCP to sign, and this then burdens the PCP and the families who are waiting for this delayed request. Other forms of required signatures that CNSs are not able to currently sign include guardianship and workmen's compensation. Nurse practitioners were given this authority last year in the 2016 legislation session. This bill would give the same signatory authority to the clinical nurse specialist as the nurse practitioners currently have. Thank you.
Thank you. Any questions from the committee? Margaret, I was just wondering, as a colleague of mine, if you could just briefly describe to the committee, it is my sense there is a spectrum as we talk about clinical nurse specialists and then nurse practitioners, and that has changed historically over time. I think many of the people with many years' experience are clinical nurse specialists, and we see newer graduates and younger practitioners becoming nurse practitioners.
Right.
Can you help us understand where that boundary is?
Originally, authority by this legislature was given to clinical nurse specialists to do reimbursement for private practice and for therapy in-house in psychiatric facilities. Then, shortly after that, nurse practitioners under physicians were also given that authority, again with reimbursement. Then, in the, I think it was mid to late 80s, prescription authority was given, again, CNSs and NPs. The next bill you're going to hear, a number of my colleagues are going to talk extensively about their practice. But clinical nurse specialists, a lot of the confusion lies in psychiatry because there's also clinical nurse specs and geriatrics and other roles. But our particular role has been eliminated as a role in terms of the last time one would sit for the exam was 2 years ago. And so all people coming out with advanced practice registered nurses in psychiatry are all now called nurse practitioner psych, or it's now called, and this is a change even in 2 years, across the lifespan. So even 3 years ago, a nurse practitioner, I think it was 3 years ago, graduate with a specialty, say, in child, adult, or geriatric. Now they're graduating in psych across the lifespan, any and all age groups in that category. And there are no more clinical specialists. I think when we estimated this last year, there's no one of us that have less than 5 years experience, and most of us have 10 to 40 years.
Thank you very much. Any further questions from the committee?
Thank you.
And I am aware that Representative Kay Khan wants to testify on this bill and on subsequent bills, and in another hearing, so we'll take it when she comes. At this point, that brings us to the sister bills of H 1067 and S 1109, an act to improve access to care by removing barriers for practice to psychiatric clinical nurse specialists. And this time I'd like to call Kathleen Andolina.
Andolina. Yes, thank you. Perfect.
Thank you.
Thank you, Madam Chairs. All right, I'm going to do this in under 3 minutes. Hello, my name is Kathy Andolina, and I have a master's degree in nursing from Boston College. I am on my 6th cycle of board certification as a psychiatric CNS. I operate my own private practice in Boston, Wellesley, and on Cape Cod, as well as function as a CNS at Harvard University, where I see the mental health needs of over 30,000 students and faculty in an urgent care setting. I work 6 days a week. Many people depend on me to continue doing what I'm doing as a clinical nurse specialist. I prescribe medications, psychotherapy, interpret genomic testing for my clients. It's a full-on practice. If my psychiatric supervisor were to stop practicing, I would have to stop caring for all my clients immediately. I would like you to find favorably for H1067 so that I will no longer practice at the risk that I may have to stop at any minute through no fault of my own. I would like to tell you about my training and how I have acquired my skills. Boston College emphasized a number of things in my training that prepared me to practice safely as a new CNS many years ago. I was supervised for every population I was assigned in different healthcare settings, multiple, inpatient, outpatient, partial, all sorts of settings. For certification, I was then required to have continued job-based and independent peer supervision for a number of years, many years. In addition to supervision, Boston College also imparted me with values such as accountability for outcomes of care and the need for lifelong learning and collaborating with others to safely deliver care. I have never forgotten those values and enact them daily in my practice. I now have a fully mature private practice. I have a website, scheduling system, billing services, expensive prescribing programs. I am listed in multiple directories and I get calls every day asking for my services. I work 6 days a week. I expect that the next 10 years of my life will be probably the most productive of my career. My clients are college students who will be tomorrow's leaders. I treat employers who run businesses and hire people that no one else will hire, like addicted people and felons. I'm very proud of my clients as employers. So I love to keep them well and healthy. I have a client who runs a sober house and is on the front lines of fighting opiate dependence on the Cape. I treat first responders, military personnel, I treat parents of special needs kids, and I treat young adults with special needs. I treat working professionals and the poor. On August 1st this year, psych CNSs will be accepted as mass health independent providers and can see individuals without being part of a clinic or a hospital. So keeping my patients well means that there should be no more disruption in my ability to deliver care. I'm very motivated to continue to do what I love to do. It's truly a privilege in practice. I'm grateful every day for the laws that were passed in 1992 that granted me prescription practice and expanded our role back then. Now our discipline is mature. We no longer are novice practitioners. There are no more psychiatrists available to supervise us. They just aren't out there. They're very busy doing lots of other things. The numbers aren't there. They are no longer want to carry the implied liability on their licenses either. Those that started with us in 1992 are aging out or retiring. If they become ill, incapacitated, or pass away, we have to stop our practices and find someone new. We need to be released from the psychiatric supervision because we have acquired the skills to safely practice. Please find favorably for H1067. Thank you.
At this time, Kathleen, there was a panel who signed up with one. I'd like to introduce them. So Virginia Tay is here, Gregory.
Jeffrey.
Jeffrey.
Phillips McEnany.
And Rebecca Evans. I'll say with you, Rebecca.
I'm Rebecca.
Okay, so in whichever order you'd like to speak.
Perhaps I'll speak because I'm going to address more of the history. Good afternoon, Madam Chairs and members of the committee. I'm Virginia Tay, Chairman of the Practice Committee for the Massachusetts Association of Advanced Practice Psychiatric Nurses, the organization which advocates for advanced practice nursing in Massachusetts. I have practiced as a clinical specialist in psychiatric nursing for over 40 years, and parenthetically, I was also a member of the initial committee for the Massachusetts Board of Registration in Nursing, which developed the concept and regulations for advanced practice nursing. I'm also a lecturer on psychiatry at the Harvard Medical School. Thank you for the opportunity to address you today. The passage of this bill to improve access to mental health services by removing the requirement for physician supervision for clinical specialists in psychiatry will increase the ability of adults, children, and families to receive care for psychiatric and addiction disorders at a time when the need for access to care is painfully acute and burgeoning. Mental health problems are highly prevalent in the United States. Psychiatric and substance abuse disorders affect 26% of adults, 20% of children, 1 in 17 adults, and 1 in 5 children have serious mental illness currently or will have at some point in their lives. Mental health disorders account for more disability than any other disorders, including cancer and cardiovascular disease. Looking to the future, the report Healthy People 2020 established 12 goals for mental health, which include reduction of suicide rates, increased treatment of depression and severe psychiatric illness, and integrating mental health into primary care and residential facilities. The ability to improve access to treatment is further compromised by the critical shortage of prescribers of psychotropic medications. The total number of physicians rose 45% between 1995 and 2013, but the number of psychiatrists rose only 12%. The demand for psychiatrists is expected to rise 19% by 2020. The need is especially acute for child and adolescent services, where the jump is expected to be 100%. There are approximately 800 psychiatric clinical specialists in the Commonwealth. The group represents the most experienced advanced practice nurses in the state. We were granted statutory authority 25 years ago with physician supervision. We could offer the alternative more effectively to expensive psychiatric care and limited availability of psychiatrists without the barrier of physician supervision. In many areas of the state, it's not possible to find a psychiatrist willing to take on the responsibilities. The physician supervision requirement is outdated and no longer necessary. Our knowledge, education, and capabilities have significantly expanded. We have a track record of safety. The reported number of malpractice suits and settlements are low in comparison to that of physicians. The Board of Registration and the Board of Medicine reduced the requirement for supervision 2 years ago. Most importantly, because of its limited scope, the physician supervision requirement is really pragmatically meaninless and does not really enhance clinical safety and clinical competence of nurses. These needs are met through supervision, I didn't mean regulatory supervision, but educative supervision, mandated education, and specialty requirements. Removing supervision.
It's a large panel, so I'm going to move to your other panel. We're going to hopefully have questions. And I'm very much hoping you're submitting your written testimony.
I am.
Okay, but if you stay seated, please. The next member of the panel would like to speak.
Good afternoon, Chairwoman and members of the committee. My name is Rebecca Evans. I'm a psychiatric clinical nurse specialist and a pediatric nurse practitioner. I've been a pediatric nurse for 21 years and an advanced practice nurse for 10 years. I have a master's in nursing and a postmaster's in psychiatric nursing. My specialty is child and adolescent with an additional specialty in eating disorders. I work in a private practice in Belmont where I see children, adolescents, and young adults. And until recently, I worked for several years providing mental health care in youth detention. Today, I would like to speak in support of 1067. Under the current state rules that govern my nursing practice, I must have a supervising child psychiatrist. I happen to have a great relationship with my supervising psychiatrist, but his role in my practice, his knowledge of my patients, is perfunctory. I have far more experience with regards to eating disorders treatment, and when I need support, I seek out guidance from other experts in this area. But I couldn't provide this care without a supervising child psychiatrist. I believe the most important and problematic aspect of this regulation is how it can hinder access to care, particularly for the children and adolescents of our Commonwealth. In my work in youth detention, my supervising psychiatrist got a full-time position and did not have time to continue her role at the facility. It took many months to find a replacement. This psychiatrist stayed on longer than she wanted to, in a much less smaller role than she was in an already small role, so that the other APRN and myself could provide care to a caseload of 40 incarcerated youth in a rotating population of over 100 youth. We're lucky that she stayed. However, we shouldn't have to rely on luck or goodwill to provide safe and appropriate care to our most vulnerable populations. Blue Cross Blue Shield Foundation of Massachusetts issued a report in 2009 regarding children's mental health service in Massachusetts, which found substantial evidence of an inadequate supply of psychiatric prescribers for children and adolescents. Most child psychiatrists and CNS practices are now closed to new patients or close to it. Many psychiatrists don't participate in commercial insurance. I do. The wait time for a child prescriber is on average 3 months. Families need to make many phone calls and follow-ups in order to locate and schedule an appointment. I've spoken to families who have called 30 to 40 providers, and I was the first to even call them back. My child and adolescent APRN colleagues who work in outpatient clinics and facilities have heavy caseloads, limited time for intakes and follow-up appointments, with an average follow-up appointment only being 15 minutes. This is for children with complicated mental health issues. So one of my peers, who happens to be the only Spanish-speaking prescriber in her large outpatient it's a clinic, had 13 clients on her schedule today, and her next time for a follow-up is 5 weeks for a clinically complicated child. There's no space in her day. This service my colleagues and I provide are desperately needed. The shortage of child psychiatrists and how busy they are makes it difficult for a CNS to find a supervisor. The shortage is likely to get worse, like she said already, and the burden of care will end up on pediatricians who are already struggling to provide psychiatric care for their patients when they do not feel trained to do so. I hope that you'll give this legislation a favorable report. Thank you.
Great. Thank you, Chairwoman and members of the committee. I appreciate the opportunity to provide testimony. My name is Jeffrey Phillips McEnany. I've practiced as a nurse for 38 years and have been a psychiatric clinical nurse specialist for the last 33. I'm in private practice in Boston. I provide clinical evaluation and treatment to about 200 people who have comorbid psychiatric and sleep disorders. In addition to my clinical work, I've been involved with academic work, and I'm currently a professor emeritus from the University of Massachusetts in Lowell. My education has included pre- and postdoctoral NIH fellowships in neuroscience and sleep. I'd like to speak in support of the bill. The requirements of supervision of clinical nurse specialists by a psychiatrist assumes that the supervisor can provide a relationship which advances learning in clinically meaningful ways. Given the specialties of the focus of my practice, securing supervision with a psychiatrist who has knowledge in a burgeoning area of science is nearly futile. Though I adhere to legal requirements to meet with a psychiatrist to review cases, the experience of supervision seems contrived and forced. For several years, I paid my supervisor $2,500 a year for 4 50-minute sessions. That averages out to $625 for each of these supervisory sessions. I provide services to people who live with major mental illnesses such as substance abuse disorders, major mood disorders, and schizophrenia, and others. Onsets of these illnesses are directly and powerfully linked with sleep, and are oftentimes the first sign of relapse, particularly in people who have diseases like that are associated with substance abuse. Deterioration in sleep during a period of treatment signals relapse, and there are strong predictors of relapse related to sleep consistently. Unidentified sleep disorders in the population of people that I work with basically carries the risk of obesity, hypertension, and cardiovascular disease, as well as diabetes. The need for clinicians who are prepared in both of these areas is huge, but is mainly unmet. This is particularly the case in me attempting to find a supervisor who would be able to provide true collaborative discussion in the areas of my work. No clinical nurse specialist in Massachusetts is a novice. We've been providing treatment, which includes prescriptive services to patients, for as long as the law has allowed us to do so in the Commonwealth. The longevity of our practices and the refinement of our skill and expertise over time places us in a very unique position. We are experts in what we do, and our clinical skills reflect our expertise. We know the art and science which drives the practice. We sit elbow to elbow with psychiatrists in the same psychopharmacology conferences where updated knowledge enlightens our practices. We are accountable to many of the same standards of practice and are all mandated to act according to the evidence-based practice guidelines. Supervision, by definition, implies a dependent relationship where the person seeking supervision basically is reliant on the expertise of the other. The exchange is supposedly mutual, but with seasoned and expert clinicians, the need for supervision wanes. Supervision is replaced with shared consultation in our duty to consult. The relationship is not dependent and does not require payment for the discussion. I appreciate your consideration of the bill.
Ms. Hay, I was wondering if I could return to you and you could describe to us the actual model. How does an advanced practice psychiatric nurse specialist connect with psychiatrists who supervise, and what does that supervision actually look like?
The way somebody would connect with a psychiatrist is by request, particularly if somebody's in private practice, or if somebody's working in an institution, a psychiatrist might be assigned to the clinical specialist. The requirement promulgated by the boards of nursing and medicine 3 years ago simply say that you need to set up a time frame that's mutually agreeable and a mechanism for discussion of your practice. So it's not necessarily a discussion of patients, it's a discussion of practice, which means you might talk about a patient, you might talk about how you approach certain things. It is extremely broad-based. It could be, with these new regulations, as little as once a year, once every 5 years, if that's mutually agreeable to you and the psychiatrist.
So I have two questions about that. Number one, and my question would be, does your organization have data on the number of advanced practice psychiatric nurses that are seeking psychiatrists to share supervision, or to do supervision? Do you know how long that wait time is, how difficult that is to make that connection? And then I think my second question around that supervision would then be around the cost. I am familiar with someone who has met with the committee who provides the services pro bono and available on a 24/7 basis. I'm hearing today that nurses are paying for this service, and it could be a period of 5 years. Is there any criteria around what that relationship is, how it's looked at, and what the reimbursement is on that?
You know, it's so variable. It is so widely variable. And people are doing it pro bono. People are doing it for much less than $600 a session. But it's all in the negotiation between the psychiatrist and the clinical specialist. In an institutional practice where somebody is salaried, there's no additional cost. There are no criteria except what's individually determined. We as a group do not have data to know quantitatively how long people are waiting. There's anecdotal data that some people are unable to begin a private practice because they can't find a psychiatrist. You know, the major issue, however, is the aging of the psychiatrists. And a lot of the psychiatrists who have agreed to supervise clinical specialists have had an ongoing relationship with them for years. And that's changing because they're aging and so are we. It's very variable, but our concern is anticipatory concern that is coming up with aging. It's also coming up because of the areas people practice in. There are some areas in the Commonwealth that it's much harder to find a psychiatrist who's willing to do it. And increasingly, psychiatrists, the younger psychiatrists, are unwilling to do it. It's unclear to them what the responsibility really entails. So they're really quite unwilling to do it. You know, parenthetically, I will say that our colleagues, the midwives, certified nurse midwives, in 2012 did achieve independent practice, and they are no longer required to practice with supervision of a obstetrician gynecologist.
Can I add something? The other part is I was looking at the data on in Massachusetts and in Middlesex County, we might be able to find a physician. But when you look at the Commonwealth as a whole, particularly in child and adolescent, there are hugely underserved populations. We're in the red in terms of the worst category in the country, like the least amount of access. And so, but we do have nurse practitioners or clinical nurse specialists working in specialties, working in psych, who are willing to continue practicing or are already practicing, but again have an aging physician or are paying higher rates, or needing to find somebody pro bono for something that they're not necessarily needing. Because somebody who's practicing, there's no, for this bill, there's no new CNSs. So no one new at practice would be out in a underserved population practicing independently. And I have two peer supervision groups, a group of clinical nurse specialists and a group of child and adolescent psychiatrists who are way too busy to supervise lots of people. So that's just, I think when we look at Middlesex County, we can get lost in that there's lots of psychiatrists around here. Why can't we do it? But when we look at our Commonwealth, there's a lot less access. Yes, and
we have one of the highest per capita population of psychiatrists and mental health professionals in Massachusetts, and we rank very low on access to mental health and psychiatry.
I just have one comment to add to the discussion, and that is that my agreement with the psychiatrist that I mentioned basically was after 6 or 7 interviews with psychiatrists who said that they weren't available to do this. It was delaying my ability to practice. And so assuming that that I could work with the psychiatrist, and I did for some years, it was the only thing that allowed me to move into private practice. Otherwise, I would have been without option.
No, you said that right now it takes 5 weeks for a follow-up. What's an ultimate time frame for a follow-up?
So if you have, like in my private practice, if I want to see somebody in 2 weeks, I see them in 2 weeks. I will expand my schedule. But if I have somebody who's urgent and I'm changing medications and they've had tons of side effects, these are kids and adolescents that I'm talking about. So if they're unstable and it's a medication-based issue or a medical issue that someone else can't provide, the psychologist can't, they're like, something's not right, but I can access. So if I want to see them next week, I want to see them next week. If I want to see them in 2 weeks. But this one that was 5 weeks, it's somebody that she was very, very concerned about.
All right,
so.
Just curious.
Thanks. Thank you. So I'm extremely concerned, as you all are, about access to care. And I was speaking with my North Andover superintendent recently, this past week actually, and we were discussing substance abuse issues and mental health issues overall. And she was telling me that it can take around 6 months sometimes for her to get a student access to a psychiatrist, actually certified to be able to handle the mental health issues the child is experiencing. So thank you first and foremost for actually coming in and trying to address these concerns through this legislation. My question is actually for Ms. Hay. And it's, you made a comment regarding the need for psychiatrists. You said it was going to increase by 19% by 2020, and then by 100%
For children.
For adolescents
Yes.
by 2020. Can you just elaborate on that a little bit about why that's the case, how you're getting that data from, and why they're saying that's going to be the case?
Because the needs, the patient needs are growing, and the psychiatric provider needs are shrinking. So it's representing that discrepancy. The growth, the needs for children is expected to grow 100%. And the providers for children are shrinking even more than for adults. That's the representation there.
Is there any data that maybe we pass on to the committee on?
I can get you that data.
You know, lack of social emotional support
Yeah.
or intervention.
I can submit that to you. Yes.
Thank you very much.
Thank you.
This time I'd like to call Lisa Simonetti.
Good afternoon, Madam Chair, members of the committee. My name is Lisa Simonetti, and I'm appearing on behalf of the Massachusetts Psychiatric Society. We have submitted very extensive written testimony on House 1067 and Senate 1109, and we remain in strong opposition to this legislation. The reasons are clearly outlined in our written testimony, and I won't take the committee's time and enumerate them. On behalf of our member physicians, we value all the clinical psychiatric nurse specialists and advanced practice nurses, along with all the other mental health professionals that work to treat our most vulnerable patients. We remain committed and willing to work with the clinical psychiatric nurse specialists to find ways of partnering in supervision, as we extended an invitation for that last year. Currently, we're polling our physicians to gather the most innovative ways that they are conducting supervision. We are looking at all the settings across the board, private, public, payer, institutions, private practices, and we hope to report back to you very shortly on what our physicians, what innovative ways our physicians are using along with technology to conduct supervision. So if you have any questions, I'll be glad to try to answer them, and otherwise I hope to report back to you soon.
So, Lisa, I do not see any psychiatrists who have signed up to testify, so I'm going to ask you this question.
Okay.
But I'm not asking you to
play my doctor on TV.
Why do psychiatrists think that clinical nurse practitioners need supervision?
It is primarily the difference in clinical training, and it's outlined in the testimony. So you're looking at a physician, a psychiatrist, who has about 12,000 hours in clinical training, and an advanced practice nurse has about slightly less than 500. And that's the basis. And honestly, Madam Chair, why, if you're going to do this, why are you just doing this for mental health patients?
Well, in fact, this is a discussion that you know is happening in the Commonwealth and has been happening for close to 10 years.
Right.
And one of the most compelling reasons is the lack of access to care that people with mental health issues have in the Commonwealth today. And what I hear is I hear that somehow if this legislation were enacted, there would not be a collegial relationship, professional relationship, and I don't understand that at all. There should be an unspoken understanding that there is a collegial relationship between a psychiatrist and a psychiatric nurse practitioner who are concerned about the same patient population. So I'm just confused at the real pushback, the opposition to this, particularly given that having met with many psychiatrists, they don't want to do the supervision. They're not available for the supervision. They want to charge for the supervision, and yet they don't want to give up their ability to have that right. So I'm just really trying to find my way through all of this.
Speaking on their behalf, I am going to say I have never once heard that there is not a collegial, a respectful relationship between any members of a team and the psychiatrist. I have never heard that. I cannot tell you any time conversation comes up how much respect and deference is given to them. We have had conversations, you have had conversations with my clients about access to barriers to access. And we have talked about it, and we are putting something together, hopefully, that we can have a much more informed discussion about what some of the actual barriers are, including payment and reimbursement. That's a little bit different than this issue, however. But we are looking at, there are 2,400 psychiatrists in the Commonwealth. That is a lot. But they are not all taking insurance. They are not all doing supervision. Certainly, it wouldn't. I don't think we would be having this kind of a conversation if they were. The question goes back to what they firmly believe, that they went to medical school, they did an internship, a residency, a fellowship, and what that 12,000 hours represents versus 500 hours. That's what it primarily comes down to as far as what we're concerned with. We offered last year to talk very extensively about how we can get our membership to start to do supervision or increase supervision or make room for supervision. And nobody was interested in having that conversation, so we dropped it. But we were sitting in Representative Khan's office and we made that offer, and we would still be glad to do that.
I think this is a discussion that you have people very interested in having these days. I recognize that Senator Keenan is present and would like to testify.
Good afternoon. Thank you, Madam Chair.
Keenan, we are grateful that you are the vice chair of this committee.
Yes, and I apologize. Yeah, I apologize for not being here. It's one of those things I find every day in this business. You can't be 2 or 3 places at once. But I do appreciate your kind consideration. And I'll be very brief on 3 bills that I think you're pretty much aware of. The first would be Senate Bill 1098, drug stewardship. Just for the record, John Keenan representing Norfolk and Plymouth Senate District. First bill is Senate Bill 1098, an act strengthening prescription drug safety and stewardship. You may recall that we passed legislation that was first of its kind in the country in creating a drug stewardship program. That is making manufacturers of medications responsible for their safe disposal. And they could do that by establishing a plan of their own, contributing to a fund that could then be used by the Department of Health, Public Health to effectuate the drug stewardship program. When the bill came out of conference committee, ultimately it contained a 5-year basically repeal clause, that after 5 years it would automatically be repealed. Now, this is first of its kind legislation in the country. It takes time for a program like this to get established, and a 5-year window is not a long enough period of time to show how effective this program could be. So what this bill would do would be to take away that provision that would automatically repeal it in 5 years and to make it a permanent program. So it would make drug manufacturers permanently responsible for taking back unused medications. And again, they could do that through their own program, or they could cooperate with the state and contribute to a fund that would then be used to provide for the responsible take back of unused medications. And the purpose of this is obviously to get unused medications out of the medicine cabinets, out of the homes, and safely disposed of so that they're not likely to be diverted and used for purposes other than which they were intended. So that's Senate Bill 1098. Next bill is Senate Bill 1099. Again, you may recall that we passed legislation that was first of its kind in the country that would allow at the state level for the partial fill of prescriptions. Now, given the uncertainty and the conflict that seemed to exist between federal law and state law at the time, there were a couple of provisions that were added to the bill as it made its way through the legislative process. What this particular bill, an act relative to patient choice to promote prescription safety, would address some of those issues that have popped up and become apparent since the passage of the legislation. For instance, as it was passed, it requires a prescriber to make a specific notation authorizing a partial fill. Physicians, those filling the prescriptions, have found that to be somewhat confusing. So what this would do would make such an authorization unnecessary, would make an authorization basically presumed for all Schedule II opioid prescriptions. So when a prescription for a Schedule II opioid is written, there's an automatic presumption that it can be filled in an amount less than what is shown on the prescription itself. There's a presumption that if this says 30 pills, that it can be filled for 15. One of the other things that we found was that while the federal law allows for the balance of a prescription to be filled within 72 hours of the partial fill, our legislation did not allow for it at the time because of the confusion between the different pieces of federal and state law. So what this would do would make our partial fill law consistent with federal law and allow the balance to be filled within 72 hours of the partial fill. And we think that takes away any confusion between the two laws. at that point. And then the third issue had to do with cost sharing. People would go in, they may request a partial fill, and it was unclear whether they would pay a partial copayment or a full copayment. And what this would do would be to clear that up, and it would require insurance carriers to allow reduced cost sharing for patients who reduce the quantity of their prescription. So in simple terms, although nothing's simple in this business, if somebody receives half their prescription, they would pay half their copay. And if they were back within 72 hours, then they may have to pay the balance of their copay when they get the balance of the prescription filled. Now, some of the pharmacies and insurers will tell you that that's difficult to do, but remember, they have that requirement and that obligation under federal law now, under federal law partial fill requirements. So as a result of what we did, the federal government actually has kind of gotten on board and is looking as well to make their partial fill legislation and partial fill laws provide for and allow what we do here in Massachusetts. So it's another thing that we get out in front of, and the federal government is following, and this would make the two versions of the federal partial fill law and the state partial fill law more consistent. Third bill is Senate Bill 1100, access to alternative pain management. One of the issues that we faced as this opioid epidemic was in its making, and as it became the epidemic that it is that there was not enough access to alternative pain management programs and techniques. That sometimes the default to handling pain was to write a prescription for an opioid. And while this legislation does not mandate coverage for alternative pain management programs and techniques, it does require a few things. It requires commercial insurance carriers to develop a pain management access plan. A plan that would say, these are the type of pain management alternatives that we are available, and it would provide them to physicians and make them aware that they are available and can be utilized. It doesn't necessarily say at this stage that insurance would cover them, but it requires commercial insurance carriers to develop these plans. And then it would allow the Health Policy Commission to consider non-opioid and non-pharmaceutical pain management plans as part of the accountable care certification process. Again, pushing the insurance industry and physicians to work together to develop these plans and take the first step in making them available to patients with the idea of whether there'll be coverage to come at a later time. It would direct the Division of Insurance with the support of the Health Policy Commission and CHIA to include access to non-opioid and non-pharmaceutical pain management standards as part of their insurance accreditation process. Again, another push. And then finally, we do a little bit of data work. Plans may offer alternative pain management programs and say, oh, they're available, and they may even say that they're covered. But the data may show that an inordinate number, disproportionate number of the claims for alternative pain management are being denied. So it's easy enough to say we offer it, here's our plan, but in practice it's not being made available to the insured, it's not being made available to the patients. And so this would gather data relative to the denial of claims that were sought to be paid for alternative pain management. So those are the three bills, and I appreciate your kind consideration of each, and would ask for a favorable recommendation on the bills. And with that, if anybody has any questions, I'd be happy to answer them.
Are there any questions from the committee?
Great.
Thank you.
Thank you very much. Take care.
And at this time, we're going to move to the two sister bills of H3205 and S1085, enacting enabling physician assistants to authorize psychiatric and substance abuse boards. I'm hoping it's Sarah Christie, right?
Yes.
So the first panel is Sarah Christie, Mark Coyle, and Russell Kelly.
Great. My name is Sarah Christie. I am a PA and also the president of MAP, the Massachusetts Association of Physician Assistants. Thank you very much for the opportunity to submit our testimony today in support of our bill, which is an act enabling physician assistants to authorize substance abuse and psychiatric holds. We have, what we would like to do with this bill is insert PAs into the list of medical professionals who are able to start Section 12 and Section 35 paperwork, which would do an involuntary commitment for substance abuse and psychiatric issues, 12 the psychiatric and 35 the substance abuse.
There are over 3,000 PAs practicing in the state of Massachusetts. We are at every point of entry for patients into the healthcare system, in the ED, primary care practices, inpatient hospital, outpatient psychiatric offices, long-term care facilities, homeless shelters. And it is within the scope of practice for a PA to evaluate, examine, and manage patients with these issues. What we don't have the ability to do is sign the Section 12 and Section 35 paperwork to get these patients on to the next step in their care. This is a large obstacle for PAs and really does disservice to our patients. What would typically happen in something like an emergency department is a PA will see this patient, they'll evaluate them, they'll deem that they are, they'll work them up, deem that they are in acute need of involuntary commitment. Then they need to step away from their patient, go find a provider who can sign this paperwork, interrupt that provider, give them the story. The PA knows the patient best, but that provider has to sign the paperwork. So this delays care, and unfortunately sometimes it actually denies care because the patient will leave during this process and they don't get to get the treatment that they need. So we think that this would help get rid of that gap in care that occurs, and we hope that you consider this and report favorably on it for us. Thank you.
I'll go. Thank you, Chairwoman Flanagan and Chairwoman Garlick. I'm here to testify in support of S1085 and H3205, an act enabling physician assistants to authorize psychiatric and substance abuse holds. This bill modifies MGL Section 12 and 35 of Chapter 123 by adding physician assistants to the list of medical professionals that are permitted to place a temporary hold on, or petition the courts to commit a patient who poses a risk of serious harm by reason of mental illness or chemical dependence. Currently, physicians and nurse practitioners have this ability, but not physician assistants, an exclusion that places the patient, the PA, and the public at risk. I'm currently an emergency medicine physician assistant for more than 21 years at South Shore Hospital in Weymouth, Massachusetts, and I also work at Milford Hospital in Milford, Massachusetts. When patients come into the emergency department, as was identified earlier in this hearing, they're often seen by a physician assistant, and we're responsible for doing their initial medical assessment, providing that they're verifying that they're medically stable to have a psychiatric evaluation. Physician assistants are often the first providers to evaluate these patients, and we know the patients better than any other medical professional. However, under current law, a physician assistant must ask the qualifying individual, either a physician or a nurse practitioner, to authorize an emergency hold or petition the court. In many cases, this qualifying individual has no relationship with the patient. A simple change in the language of a Section 12 and Section 35 of the general laws will keep both patients and the public safe and will allow patients to receive necessary treatment expediently. Thank you for your time. I once again urge your support of this bill out of committee. Thank you.
Russell Kelly, Committee Chairman, Flanagan, Chairman Garlick. I'm here to testify in my support of Senate Bill 1085 and House Bill 205, an act enabling physicians to authorize psychiatric substance abuse holds. I would just like to mention that by not doing this is a delay in care, because as my colleagues have mentioned, when you do the initial assessment and then you have to step away and find somebody else to validate your findings, which I found has happened, it delays the care. So like a Section 12, if a 12A allows for a medical evaluation to determine if they have a delirium, if they have a UTI, if there's medication interaction, those are addressed first. And then if none of those are found to be in play, then a 12B could be placed so that they go into a psychiatric unit for up to a 72-hour hold. It's not a mandated time that you have to be in. It allows us to access them, and if they are found to be doing well before that period, nobody's going to hold anybody against the will. Nobody wants to take anyone's freedom away. We want to assist them. We want to be able to get them back into society and doing well. These are all temporary things to stabilize somebody, not to confine them in any way, unless that is what is needed for their safety and the safety of others, and that is for a limited amount of time.
Thank you very much. Thank you. Any questions from the committee? Hearing none. Susan Fendel, sign up to testify.
Our Mental Health Legal Advisors Committee opposition to this bill is quite the same as our opposition to the expansion of Section 12, Section 35 authority to licensed mental health counselors. It is very rare that people are released before being held a substantial amount of time. And we know about boarding in the hospitals. We know that there are difficulties with hospital costs. These bills are not going to help. And if we're really serious about helping people with mental illness, we need to look at things other than involuntary commitment. We need to look at investing in outpatient community services and not in services that discourage people, involuntary services that discourage people from seeking mental health care. And I will provide those peer review articles for you concerning what happens to people in medical settings in terms of their physical health care if they are tagged for one reason or another as having a psychiatric diagnosis.
One thing I will say, comment I will say, and I won't rehash what I said before, is that the number of ambulance calls for mental health patients is now through the roof. So it's not as if people are afraid to get treatment because they're calling 911 to get help. So I think when you know the Mental Health Legal Advisory Committee says people are going to be afraid to get help, they're calling the ambulance to come get them. They know where they're going. Because in Massachusetts, you have to go to an ER. I would love to change the regs that we could bring you to a mental health stabilization program or a mental health ER, but I don't buy the fact that people are afraid to get help and that everyone thinks they're going to be held in Section 12. I think that people are seeking help. They're desperate for help wherever they can get it, and the ambulance seems like the easiest way to go. I've seen in hospitals where ambulances bring them right in the back door, through the front doors, and into the waiting room because there's so many people waiting for services that, you know, again, my concern is to get help for people. I don't think they're as afraid of getting help as we'd like to think. I know they're a peer review, but I'm telling you what I've seen in 2017 is not what I saw in 1996 when I started in this building. And I think that the important thing is that we have tools in the toolbox and knowing what we know about how quickly things can go south. We have to be able to treat people. You know, just because someone has a diagnosis and we fight this every day, the governor's fighting this every day, the stigma thing has to go away. So for us to keep fighting it, it's the same. We're not going to stereotype. Just because you have a mental health disorder diagnosis doesn't mean we're not going to treat you medically. Doesn't mean that you have a medical condition. But we also know through peer review, and I'm sure the chairman will corroborate this, they go hand in hand. Your medical conditions with your mental health conditions go hand in hand. And I think as a Commonwealth, we have an obligation to treat them. If we can start to look at who can begin the paperwork, Section 12 is not easy. You got to prove it. You got to prove 35. You've got to get people involved. It's not as if one person signs off and that's it. That I think we really have to start to have this conversation and stop worrying about the fear factor of if someone's afraid to get treatment. Because the reality is, in my district, they call the ambulance all the time. My fire departments, because we have fire service-based EMS, they'll tell you, their medical services, their mental health, are climbing every day. That I think we need to take a look at this, and just looking at those numbers specifically kind of force us to look at this, as to who can help in the emergency rooms. We know they're short-staffed. We know the hospitals aren't hiring everyone that they should. We know that people are seeing, physician assistants or LHCs or social workers or whomever, and we need to finally start to move forward.
If they're really seeking inpatient care, then it seems like a Section 12 would be unnecessary because you would not have to put a hold on them. What they are seeking is after-hours care, which is usually not available, and they are seeking other forms of care, pure respite, a place they can go where they feel comfortable to deal with the crisis they're going through. Rather than expanding involuntary care, I agree with you totally. We need to have the ability for ambulances to take people to places other than emergency departments, to crisis stabilization, to peer respites. We need to provide for community services that are available after hours. Sometimes people just need refills on their medications or are having a reaction to their medication. And they don't have those after-hours facilities. But I don't think we need to expand involuntary services. Thank you.
Actually, I'm going to ask you to stay seated. And Kelly was a very new chairman on the committee. I am deeply moved by the fact that these hearings, and I've served on a variety of committees where there are many people in the room or in on the committee that are concerned about certain aspects. When I am in this room, I always have the sense that all of us on the committee and everyone in the room is deeply involved around their concern around the issues of mental health for residents of the Commonwealth. And we're all trying to figure this out together. We have heard all the bills on the agenda, but I am aware, Susan, that you had also signed up, had come in late, and had signed up to testify on Senate 1098, Senate 1099, and Senate 1110 that has the sister bill of H3204, and I want to give you the opportunity if you wanted to speak.
I will be very quick. We support Senate 1098, and it seems like a good common sense bill and should be given more time to prove itself. We also support Senate 1099, but we would like for it to be a little clearer that insurers must not only allow for reduced copays, but that those copays must be reduced if there are partial bills. And one last thing is that we would hope that the prescription to get the rest of a prescription filled, the limitation to the same pharmacy be removed, given we have a system of checking electronically in terms of who is filling these prescriptions. The requirement to have it filled at the exact same pharmacy could be problematic for people who begin to experience pain when they're not in the vicinity of the original pharmacy.
Hearing no further comments, having covered all the bills on the agenda, this public hearing is adjourned.
Good, thank you.
All right.
Thank you for your testimony.
That people realize they hold
Because you just said to me, okay, you said to me, don't treat them and give them their meds where okay. Come on. No, I'm saying we were thinking that. I just want to make sure that the medical necessity is part of it. And then we'll have written comments to this. Okay. I want to hear the testimony first and update.
Sure, yeah.
Okay, thank you.
They do our calling. If we don't get a section 12, if they're saying, take me to the hospital, take me, put me in hospital.
Yeah, but why not? If they're volunteering, you're volunteering with the hospital. So what happens to you at that point? There were 3 things that that's what needs to be involuntary.
They can do voluntary.
I see it differently. I mean, can you see the legal side of it? Oh, yes, sorry.
You kind of never agreed.
When I'm in the ERs, and I see things like that, and I see them, oh, I'm gonna hurt myself. Don't be able to hurt myself. Okay, that buys you 3 days. You know it does. They're not gonna let you go. Well, they're this, they're that. It's not as Pollyanna as everyone's like, I wanna go.
But we have people and there's some people, yes, absolutely. And there are other people. But it's never both sides. There's definitely both sides. Somebody, I don't know how it works. I don't know what you're going to do. Yeah, so I don't know what the process is when you license to another state. You know,
But then, but if I didn't do that, and you went and tried, then it's my fault. Then it's my fault. If you did that, no. You can't do that. Right, but you also know that if they went out and did something, it's my fault. And you can't say it's not. It's always the provider's fault if someone says a wrong comment and then it's not. And then I have a mental health about that's what I do. Just one of them walk away. So I can't. And now more than ever. Okay. Clinicians are okay. Yeah, so if you have any, they're not. Stop using the ER as your it's her fault. Stop using the ER as your clinician. Right. Because they also have different providers. Okay.
Yeah, so we just, I told them.
Yeah, well, that's the part that's difficult. You can't balance it. But you know that, but you know it's not covered.
It's broken, yeah.
They're not covered. They're not doing yeah, but we're going to mandate all that, but you can't mandate this. You can't have both ways.
They guys get first too early and have would you add someone to page that's what it was. It was definitely. Yeah, it's just come back. But
Yes,
yeah,
and I do want to do that. My only thing is that I want to.
way better because there was also like chicken chops. It wasn't like a chop.
I want to actually know the people that make what people are because
I'm trying to get this straight.
I appreciate that. I want to go there. Like process how so we're just trying to see how long and people tell what their rates are.
That's fine with me. Because they asked me, and I'm like, they haven't so bad.
So let me do that. Stuff that would just be general stuff. Yeah.